Αγαπητές φίλες και φίλοι, καλησπέρα σας και χρόνια πολλά. Είναι η 20η χρονιά που κάνουμε το συνέδριο του ΩΜΑ υπό την αιγίδα φέτος του Ελληνικού Κολεγίου Οφθαλμολογίας, αλλά δυστυχώς θα είναι διαδικτυακό. Δεν θα έχουμε τη χαρά να βρεθούμε όλοι μεταξύ μας. Φυσικά πιστεύω ότι του χρόνου, μετά από το σημερινό και το φετινό διάλειμμα, θα μπορέσουμε να είμαστε πάλι όλοι μαζί αυτό το διήμερο. Για φέτος έχουμε φτιάξει ένα πολύ ενδιαφέρον πρόγραμμα αυτό το διήμερο και ευελπιστώ ότι θα το ευχαριστηθείτε όλοι σας. Μπορείτε να συμμετέχετε φυσικά μέσα από τις ερωτήσεις σας, τις οποίες μπορείτε να στέλνετε και πιστεύω ότι όλοι οι ομιλητές θα μπορέσουν να ανταποκριθούν έστω από μακριά σε όλες τις δικές σας ερωτήσεις. Θέλω να ευχαριστήσω το Ελληνικό Κολέγιο Οφθαλμολογίας, το οποίο έβαλε την αιγίδα. Είμαστε κοντά στους Έλληνες οφθαλμιάτρους και έχουμε διάφορα σχέδια, τα οποία θα τα ανακοινώσουμε μέσα από το καινούριο site το οποίο ετοιμάζουμε. Θα ξεκινήσουμε με πολύ ενδιαφέρον course πάνω στην ογκολογία, το οποίο θα το διευθύνει η κυρία Πευκιανάκη, η οποία έχει έρθει πρόσφατα από την Αμερική. Θα καλέσω την κυρία Πευκιανάκη να παρουσιάσει στους ομιλητές. Το course αυτό είναι πάνω από 2 ώρες. Είναι καλό να κάνετε ερωτήσεις για να πάρουμε τις απαντήσεις από τους πολύ έγκριτους συμμετέχοντες σε αυτή την τράπεζα. Στη συνέχεια έχουμε ένα πολύ ενδιαφέρον τραπέζι της οφθαλμοπλαστικής από 2 γνωστούς οφθαλμιάτρους και φίλους, το Γιώργο το Χαρόνι και το Θανάση Τορμελιώτη, και θα τελειώσουμε το βράδυ στις 7.30 με την κυρία Καμακάρη, η οποία θα μας κάνει μία ομιλία γύρω στα γενετικά. Αύριο το πρωί, σε 9.30, θα συνεχίσουμε. Η πρώτη στρογγυλή τράπεζα έχει να κάνει με την χειρουργική του επιστημορίου. Για να μην καθυστερώ άλλο, θα δώσω άμεσα το λόγο στην κυρία Πευκιανάκη. Θα τα πούμε αργότερα. Ευχαριστώ πάρα πολύ. Κυρία Πευκιανάκη, ο λόγος σε εσάς.
Θα ήθελα και εγώ με τη σειρά μου να ευχαριστήσω θερμά το Οφθαλμολογικό Ινστιτούτο ΩΜΑ και ιδιαίτερα τον κύριο Δατσέρη και το Ελληνικό Κολέγιο Οφθαλμολογίας για την πρόσκληση να συμμετάσχω σε αυτό το συνέδριο που πλέον έγινε θεσμός στην επιστημονική κοινότητα και να παρουσιάσω στα πλαίσια του συνεδρίου αυτού το πρώτο μου Διεθνές Κλινικό Φροντιστήριο Οφθαλμικής Ογκολογίας. Ευελπιστούμε όλοι ότι τα θέματα του κλινικού φροντιστηρίου αντανακλούν τα ενδιαφέροντα και τους προβληματισμούς όλων των οφθαλμιάτρων κάθε υποεξειδίκευσης. Εμείς, σαν Έλληνες, έχουμε τη μεγάλη τιμή να έχουμε Έλληνες οφθαλμιάτρους με εξειδίκευση στην οφθαλμική ογκολογία, γνωστούς καταξιωμένους παγκοσμίως, τον κύριο Γραγούδα, τον κύριο Ζωγράφο, τον κύριο Μπεχράκη, που τόσα χρόνια διέγραψαν μια πολύ μεγάλη πορεία στον χώρο της οφθαλμικής ογκολογίας. Αν εμείς, η επόμενη γενιά των οφθαλμικών ογκολόγων, κατορθώσει να προσεγγίσει έστω και ελάχιστα ό,τι έχουν κάνει, θα είναι πολύ μεγάλο μας επίτευγμα. So, colleagues, ladies and gentlemen, it's my pleasure to welcome you and formally open this conference. It's my distinct honor and high privilege to introduce you our very distinguished panelists, Dr. Damato, Dr. Cassoux, Dr. Suati, and Dr. Frenkel. Each of them pioneered in the field of ocular oncology. We are all hoping that we can bring together some valuable experience from some of the best ocular oncology centers in the world. We will be discussing today about choroidal melanoma, tumors of the fundus, about some of the eye cancers in children, about orbit tumors, and about tumors of the anterior segment. Unfortunately, Dr. Cohen, she can't join us today. She wasn't feeling very well, and unfortunately, she has admitted to the hospital. We are all wishing her a very speedy recovery, and hopefully, she will be able to join us in one of our next courses. Dr. Cassoux kindly will cover also her topic. If you have any question, please type your question in the appropriated box, and at the end of each talk, I will ask the questions to the speaker. So, we are all very, very pleased today to have Dr. Suati Kaliki from the famous LV Prasad Eye Institute. Dr. Kaliki heads the Orbit and Ocular Oncology Unit at LV Prasad Eye Institute. She is the recipient of over 150 papers, 8 chapters on various ocular tumors. She is also the recipient of Achievement Award from American Academy of Ophthalmology in 2014, and in 2019 she was shortlisted among the top 3 finalists at the Women in Science Award category from Young Scientist Awards 2019. Congrats. Dr. Kaliki is going to talk to us today about the approach to pediatric proptosis. So Ati, thank you very much for accepting my invitation. I know it's too late in India. Please, let's give her a very warm virtual welcome to Swati. Over to you.
Thank you very much, Maria, first of all, for organizing this oncology conference in Greece and making me a part of the conference today. A very good evening to everyone there in Greece and to everyone who is logged in to listen to the wonderful talks that I'm sure that will be there throughout the conference. So I'll start sharing my screen. Okay, so I will be talking about the orbital tumors in children specifically. I'll be showing you a couple of cases so that we have a greater understanding about the orbital tumors in children. I do not have any financial disclosures to make, and full face clinical photographs will be used in my presentation, and appropriate permission has been obtained from the patients. We'll start with this case number 1. So this is a child, a 3-year-old child, a 5-year-old child who presented with history of pain, redness, swelling, and proptosis that is very much visible in the right eye for the past 4 days. There was some vague history of trauma that the parents were giving, but there was no history of fever that could be noted. On examination, the child did not have any vision in the right eye, while the left eye was normal. There were obviously signs of inflammation that were present in the right eye. So whenever we have a cellulitis-like picture in a child, we should not assume that it is a cellulitis of infectious etiology. Because as you can see in this child, this is the CT image that the parents were carrying along with them. And here we can see that there is an intraocular mass in both eyes, in fact, but more so in the right eye with calcification in the center. And in the left eye, you can see that nasally there is an intraocular tumor. And this is the B scan of the same child. And it is very clear that there is an intraocular mass that is present in the right eye with areas of calcification showing the posterior shadowing wherever there are areas of calcification. So this, in fact, is a case of bilateral retinoblastoma, which was mimicking an infectious orbital cellulitis, but it is not an orbital cellulitis, but it is right orbital pseudocellulitis. So pseudocellulitis in a case of retinoblastoma is not a very common picture that we see, but we do see these cases in about 1% of the cases where the tumor undergoes necrosis and it causes inflammation of the orbital tissue. So how do we go about managing these cases? So these children do not require oral antibiotics, but they require intravenous steroids. So intravenous steroids are given for about 48 hours. And once the inflammation subsides, and if the child does not have any extraocular extension, we go ahead with enucleation of the right eye. And of course, the child also requires treatment for the left eye because the tumor is bilateral. So this is what was done in this child, so that the right eye, what you're seeing is a prosthetic eye where enucleation has been done and a prosthesis has been placed. And the left eye, the tumor is controlled with chemotherapy and focal treatment. So the clinical pearl that we have to take from this case is that whenever there is no fundus view or for the child, it is very important to do an orbital or ocular imaging so that we do not miss any intraocular tumor. Because most of the times what happens is these children come to the emergency and they may be misdiagnosed as infectious etiology and just put on antibiotics, and the main etiology itself is lost. So that is why fundus examination is mandatory. If fundus examination is not possible, then at least an imaging should be done. Let's move on to case number 2. Now, this is a child who presented with redness. So this is a 1-year-old child who presented with redness, swelling, and proptosis of the right eye for the past 1 month. Again, there was some vague history of trauma. There was no clear-cut history there, and there was no history of any fever. This child, in fact, was diagnosed. The child had visited a pediatrician before coming to us, and the child was diagnosed to have maybe an eyelid infection or inflammation, and the child was already on antibiotics. But is this really an infection or inflammation? This is what the child had on imaging. So this is the MRI orbit, and you can see that the left orbit looks absolutely normal, but the right orbit, there is ill-defined heterogeneous lesion that is present, which is not just present in the eyelid, but it is extending into the orbital tissues as well. And this can be even better appreciated with this contrast scan, as it can be seen that the entire lesion is just lighting up with this contrast. So in fact, this was a case of capillary hemangioma, the infantile hemangioma that the child had, and it was not an infectious etiology. So how do we go about treating these cases? So first we get a physician review just to make sure that the child does not have any contraindications to the treatment that we would offer to this child. The first line of management of the infantile capillary hemangioma nowadays is the oral beta blockers, specifically oral propranolol that we give for them. We give them at a dose of 1 milligram per kg body weight for a week. And once they tolerate the drug well, we escalate the dose to 2 milligram per kg body weight. And we continue the treatment till the desired effect is attained. And then slowly we taper them and then stop. We do not stop them abruptly. If we stop the treatment abruptly, then these children will have rebound phenomenon and the lesion may reappear again. That's why we do a very slow taper. This is the same child after treatment, and you can see that the lesion has completely regressed and there is no residual lesion that is present in the right eye. Now, this is another example. This is again a capillary hemangioma, the infantile hemangioma that is present, but here it is much more diffuse. So you can see that it is affecting almost the right half of the face, and even in the periauricular area, there is a swelling that is present, indicating that there is a deeper component as well. Now, this is the imaging of the same child, and this is the contrast MRI, and it can be seen that there is extensive lesion that is present in the right orbit and in the right preseptal space. And this is the same child after initiating treatment, and you can see that there is minimal residual lesion now, which would disappear with age. It's not that all cases require treatment, but whenever it is causing significant ptosis, or if it is inducing astigmatism, these patients require treatment. Moving on to case number 3. Now, this is a child who presented with left eye proptosis. The right eye was absolutely normal. 4-year-old girl, and the child also had pain in the left eye for the past 3 days. There was no history of trauma or any fever that was noted. And this is on imaging. This is the CT scan where we can see that the right orbit is normal, while in the left orbit, there is diffuse ill-defined lesion, which is in the intraconal and the extraconal space. Now, this is a case of left orbital venolymphatic malformation, or what we commonly call it as lymphangioma. So now the first line management of these lymphangiomas or the venolymphatic malformations are sclerotherapy. Previously, in the previous, maybe 5 or 6 years back, we used to go ahead and do surgery for these patients. But nowadays, with the advent of sclerotherapy, we do not require any extensive surgery in them. So what we did for this child was sclerotherapy with bleomycin. This is the sclerosing agent that was used in this case. And you can see that the result is very good, where the lesion has completely disappeared. This child, we had to just give 2 injections of bleomycin with an interval of 2 months, and the lesion completely disappeared. Moving on to case number 4. Now, this is a child who presented with proptosis of the right eye for the past 1 month. He had history of fever on and off, and there was no history of trauma, though there is a small abrasion like that can be seen below the left lower lid, but the parents did not give any history of trauma. And on examination, his vision in the right eye was 20/40 and in the left eye was normal, being 20/20. And we could palpate that there was a firm palpable mass that was present in the right orbit. Now, this is the imaging that was done. So this is the CT scan of the same child, and it can be seen that there is a more homogeneous isodense mass that is present in the right orbit, which is involving the extracorneal and the intracorneal space. And the lesion is also present in the left orbit, though it is not as prominent as in the right eye, but the lesion is bilateral. Now, whenever we see such homogeneous lesions in a child, we have to suspect that this could be a case of granulocytic sarcoma, which was what was in this child. That means this is leukemia, which where there is infiltration of there are leukemic deposits in the orbit, what we call as the chloroma or the granulocytic sarcoma. Now, what will we do next? Do we do biopsy in this child? No, we do not have to do biopsy in these children. First thing that we have to do is do a peripheral blood smear. So which was what was done in this child, and the peripheral blood smear revealed that there are blasts that are present in the peripheral blood smear. And these cases, we really do not have to do biopsy to prove the diagnosis. So we already know that this is a case of acute leukemia. So this child, in fact, had acute myeloid leukemia, and the child was started on appropriate systemic chemotherapy. So the clinical pearl here is that whenever you see rapid onset of proptosis with a bilateral soft tissue homogeneous lesion in a child, suspect granulocytic sarcoma. Before we jump into do an incisional biopsy based on the CT or MRI findings, we have to do a peripheral blood smear, and we could arrive at a diagnosis by the most non-invasive method by just doing a blood test. Moving on to case number 5. Now, this is a child who presented with an 8-year-old boy who presented with proptosis of the left eye for the past 20 days. And he was diagnosed to have a non-specific orbital inflammatory disease elsewhere. He was seen elsewhere, and he was diagnosed to have orbital inflammatory disease, and he was put on oral steroids for the same. But the father noticed that the proptosis was just progressing, and the child was referred to us. On examination, the child had a vision of 20/30 in the right eye and 21/25 in the left eye. And on palpation, there was a firm palpable mass in the left orbit. And this is the CT scan of the child. And you can see that there is a homogeneous, a well-defined mass that is present in the lacrimal gland area, which is extending almost till the apex of the orbit. So with this picture, we made a differential diagnosis of granulocytic sarcoma, just like what we saw in the previous case. So we thought this could be a granulocytic sarcoma, and we also kept a differential diagnosis of rhabdomyosarcoma. So first we went ahead, and because we had a diagnosis of granulocytic sarcoma, we did a peripheral blood smear, and the peripheral blood smear was absolutely normal. So we went ahead, so we thought, okay, this doesn't look like granulocytic sarcoma, and then we went ahead and did a biopsy in this child. And on biopsy, it can be seen that there are large cells that are present with large nucleus and high mitotic figures that were noted. But Desmond stain was negative and Myo D1 was also negative, indicating that this is not arising from the muscle. So this was not rhabdomyosarcoma. But myeloperoxidase stain was positive, indicating that it is a acute myeloid leukemia. And the bone marrow showed that there were in fact blasts that were present, which was not evident on peripheral blood smear. So initially we had ruled out granulocytic sarcoma, but by histopathology, we came to a diagnosis that it is indeed a case of granulocytic sarcoma. So this was a case of, again, AML, that is acute myeloid leukemia, and the child was put on appropriate chemotherapy. Now, the pearl here is that sometimes the peripheral blood smear may be negative, even though it is a case of acute leukemia. So negative peripheral blood smear does not rule out granulocytic sarcoma. The child can have what we call as aleukemic leukemia. So aleukemic leukemia is a type of leukemia where the peripheral blood smear, it remains normal. The changes would be seen only in the bone marrow. So the peripheral blood smear may not be helpful in such cases. Moving on to case number 6. So this is a child who presented with a painless proptosis of the left eye since 2 months. There was no history of fever or trauma. And this is the CT image of the same child, where it can be seen that the right eye is normal, while in the left orbit, there is a well-defined lesion that is present in the lateral orbit. And in fact, the part of the sphenoid bone was also missing in this, but the dura was intact. There was no intracranial extension. So with this clinical picture and the imaging, we came to a differential diagnosis of that it could be a case of Langerhans cell histiocytosis or eosinophilic granuloma, or a case of primitive neuroectodermal tumor, or the Ewing sarcoma. We went ahead and did an incisional biopsy in this case, and it can be seen that there are large polygonal cells with abundant eosinophilic cytoplasm that is present within the cells. The CD68 was positive, S100 was positive, indicating the histiocytic origin of this lesion, and CD1A was strongly positive. So whenever CD1A is positive, it is pathognomonic of Langerhans cell histiocytosis or eosinophilic granuloma. So this is what this child had. Now, how do we go about and treat this case? Now, whenever we see a case of eosinophilic granuloma, it is very important to do a systemic workup, including bone marrow biopsy, a bone scan, complete blood picture, and whole body PET CT. And also we should rule out diabetes insipidus, because these children have tendency to develop diabetes insipidus. And the way we treat this is, if it is isolated or vital lesion, we can do intralesional steroids. And if it is multifocal involvement, then these patients also require systemic chemotherapy. So this child, we gave intralesional steroids. The 6-weekly intralesional steroids was given, in the Kenacort was given for this child. And you can see that with 2 injections, the lesion nicely regressed. And when we do a repeat CT after, say, about 6 months, the bone also would have reformed. Now, this is another child who presented with proptosis of the right eye, and there was no history of fever or trauma. And this is the CT picture, where we can see that there are multifocal lesions. You can see one lesion in the right orbit, and even in the skull bones, there is a osteolytic lesion that is noted. This child, in fact, had multifocal eosinophilic granuloma, or the multifocal Langerhans cell histiocytosis. So this particular child required oral steroids and systemic chemotherapy. So this is the child after 1 cycle of chemotherapy, and this child is still on treatment as of now. Moving on to case number 7. Now, this is a child who presented with a painless proptosis of the left eye since 1 month in the left eye. There was no history of fever or trauma that could be noted. And on MRI, there was a large mass that was present in the left orbit, which was pushing the globe forwards. With this, we made a clinical diagnosis of rhabdomyosarcoma because it was a child in the first decade of life and there was rapid increase in the size of the lesion, and imaging showed that there is a well-defined lesion. So with this in mind, we made a diagnosis of rhabdomyosarcoma. A systemic workup is indicated in these cases, which includes a bone marrow biopsy and a whole body PET-CT to see if there is any systemic metastasis. In this child, we went ahead and did a swinging eyelid approach to remove the orbital tumor, that is the transconjunctival. What you see in dotted lines is the transconjunctival incision we gave, and then we did a lateral canthotomy and cantholysis, and we could remove the tumor in toto. This is the tumor that has been removed, a fairly large lesion that we could remove. Grossly, there was no residual tumor that was left behind. And this is the histopathology picture where there is a capsule that is present and it is densely packed cells that can be noted with the high mitosis rate. Here you can see a high MAC picture where it is arranged in fascicles, and there is a lot of mitosis that is visible on this picture. Now, Desmond was strongly positive in this case, and MyoD1 again was strongly positive. Vimentin also positive, indicating that this is a case of embryonal rhabdomyosarcoma. So whenever we see a case of rhabdomyosarcoma, we have to determine what type of RMS it is, whether it is embryonal, botryoid, spindle cell, alveolar, or pleomorphic. It is important because botryoid and spindle cell rhabdomyosarcoma have a good prognosis. Embryonal has an intermediate prognosis, while alveolar and pleomorphic have poor prognosis. And also, it is important to determine what stage it belongs to, because the treatment varies. If complete resection has been obtained and the lesion is well encapsulated, then we can simply observe. But if there is microscopic residual disease or the lymph nodes are involved, then they require chemotherapy and the radiotherapy. Stage 3, again, they require a combination treatment, while stage 4 requires palliative care. The clinical pearl here is that whenever orbital rhabdomyosarcoma is suspected, aim for complete surgical excision of the lesion, because this improves the survival rate. Avoid only incisional biopsy. Excisional biopsy should always be aimed whenever RMS is suspected. So this is the same child where we excised, and also this child also received chemotherapy because there was suspected microscopic disease. So to summarize whatever I've spoken now, whenever it is a case of pediatric proptosis or where there is an orbital tumor in a child, we have to look at various factors. What is the age of the child, laterality of the disease, whether it is acute or chronic onset, progressive or non-progressive lesion, get an imaging of the orbit, CT or MRI, whatever is available. And systemic screening is important in certain conditions, like I have discussed certain cases. And we have to plan whether this particular orbital tumor requires excisional biopsy or an incisional biopsy, or just a medical treatment is sufficient. With this, I end my talk. So here is my email ID. If any of you have any additional questions or you want to reach out, you can certainly send me an email. Thank you very much.
Thank you very, very much, Dr. Sati, for the wonderful talk. As always, your talks are very, very interesting. We always was looking at your cases. And I have a question for you. In cases of babies with a lesion similar to dermolipoma, when we have the lesion, when it has features similar to orbital fat on CT or on MRI, what would you do? Would you just wash the lesion? Would you remove the lesion? If the lesion is large, when would you remove the lesion, if you had to remove the lesion?
Yeah, so whenever we have a case of dermolipoma in a child, which is a fairly common thing that we see, we can either observe, not always that we have to excise. So if it is a small lesion hidden beneath the eyelid and you do not see the lesion unless you actually elevate the eyelid, then such cases we can simply observe. We don't have to remove them. But if it is large, if it is large enough that it is seen in the palpebral aperture, or if the child is having difficulty because of that, when I say difficulty, that means there could be problem with the tear film not being spread evenly, because when the eyelid kind of closes, there will be a dry spot there. If it is that large, only then we advise excisional biopsy. So all cases of dermolipomas do not require excision.
Thank you very much. Thank you very much. Thanks for joining us. I know that it was very late in India, so thank you very much. I hope see you soon.
Thank you. Thank
Bye.
you.
Bye.
Yeah. Bye.
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 So it's my very great pleasure now to introduce our next speaker, Dr. Nathalie Cassoux. Dr. Cassoux is a full professor in ophthalmology in Paris and head of the Ocular Oncology unit at Institute Curie. She is also president of our European Ocular Oncology group. She is always organizing several international multicentric studies, and among the other things, devoted mostly to uveal melanoma and retinoblastoma research. She has written more than 130 published articles, and she received also the American Academy of Ophthalmology Prize. Dr. Cassoux, at her first talk, she will speak to us about the management of uveal melanoma. Please join me in giving a very warm welcome to Dr. Nathalie Cassoux. To you, Nathalie.
Do you hear me?
Yes. Yes.
Hello?
So nice to see you again.
Calimera?
Kalispera.
Just to say that I am not the president of the OOG, I'm the past president.
Thanks. Okay. You go ahead.
The first talk is actually, I think, the first talk is the retinoblastoma one.
Okay, perfect. It's also
So
this one. Okay.
if it's okay for you.
About retinoblastoma, and we are really hoping in Greece in near future we will be able finally to treat cases of retinoblastoma also in Greece. So we are all listening to you.
So we are going to see some guidelines for the diagnosis and the conservative management of retinoblastoma. Okay. Conservative or not conservative.
Okay.
Depends. At the Institute Curie, the first treatment of retinoblastoma started many years ago with the start of external beam radiotherapy by Dr. Dollfus at that time. And 20 years ago, after a decision of French government, it's okay.
It's okay now.
So retinoblastoma is a rare pediatric cancer with a relative stable incidence. This disease is due to a double hit on the gene of retinoblastoma gene, and it follows what we call the Custom model. This nice paper that was done by Didier Fabian and all the team show that there is a huge disparity between Europe and Africa, for example. In Europe, the child are younger and the presentation is less advanced than in Africa patients. And of course, the survival is also totally different. So for some simple genetic, the unilateral form is due to a first hit in one cell, in one retinal cell, and then the double hit will give you one tumor in one eye. The sporadic or familial retinoblastoma, which is with the boy is carrying, or the girl, a germinal mutation of on the retinoblastoma gene. All the retinal cells carry one hit, and then a second hit can occur in a different point of one eye or two eyes, and you have a bilateral retinoblastoma with more than one tumor per eye. The first clinical symptoms are the early one is leukocoria and unilateral strabismus, and the European presentation is usually the early presentation. Sometimes you can see more late presentation with ophthalmia, neovascular glaucoma, pain, and very rarely phthisis bulbi. And you have also advanced presentations, proptosis with regional lymph node metastasis and present systemic metastasis. So this is a case of leukocoria. Leukocoria is easy to see with the pictures on the smartphone. And of course, in case of leukocoria, the child need a complete examination with the fundus and an ultrasonography and an MRI. It's the same for strabismus. You do not take a permanent strabismus for an accommodative strabismus. And the rule is that every child with strabismus need a complete examination of the fundus. This is another case of leukocoria. So as I said, there is two presentations, unilateral form and the bilateral form. The unilateral form are usually diagnosed a little bit later than the bilateral form. Here you can see a big white mass with a retinal detachment and an invasion of the vitreous by the tumoral cells. And in this case, you have a bilateral form with many tumors, 5 in the right eye and 2 in the left eye. And the tumor are characteristic, white, and with a bit of calcification inside. Another example of a big tumor with vitreous invasion. It is another form with when the tumor is associated with retinal detachment. And this can be a pitfall because sometimes the presentation is you can see only complete retinal detachment, and sometimes you cannot see the tumor. So even in a child, you need to explore a total retinal detachment if unilateral, because it's very rare to have a retinal detachment traumatic, for example, in the children of less than 2 years old. So stay vigilant in case of total retinal detachment, in case of unilateral neovascular glaucoma, in case of unilateral ophthalmia, unilateral intravitreal hemorrhage. Sometimes it can be also a pseudocellulitis or a pseudohypopion. This is a case, the child presented a total retinal detachment that was diagnosed at the beginning as traumatic, but finally he had an exploration with an MRI, and you can see that there is a big tumor inside the eye, and also in ultrasound with calcifications, which is a classic for retinoblastoma. This is also a poor child that was followed during 2 years for traumatic retinal detachment. And you see that there is a tumor inside the eye, and during the 2 years, the tumor evolved. And there is here an extrascleral extension, an invasion of the optic nerve to the chiasma. Sometimes you have also some inflammatory presentation, like this, there is eyelid edema. And in this case, you can see that there is a sort of inflammation, but you see here that there is a sort of hypopion with a cataract. But this hypopion is not like an inflammatory hypopion, because if you move the eye, you will see the hypopion will move with the ocular movement. And this is a sign of cellular hypopion. And this is retinoblastoma. And in this case, there is total retinal detachment. And if you do an ultrasound echography, you will see the tumor. Another case of neovascular glaucoma with ophthalmia. And in generally, it's unilateral. This is more advanced cases with the proptosis. And this proptosis is due to huge exteriorization of the tumor inside the orbits. And you can see that this child had a bilateral retinoblastoma. This is also a young patient that came from Africa with this huge proptosis. You see here there is an invasion of the soft tissue of the orbit end of the face. There is lymph node metastasis and systemic metastasis. And despite huge treatment with systemic chemotherapy, unfortunately, these children didn't survive. This is the imaging of the vast invasion of the soft tissue of the face. Another pitfall is a diffuse infiltrating retinoblastoma, when tumor cells can invade the retina and the vitreous and the anterior chamber without a clear mass. There is generally a retinal detachment, vitreous seeding, and a hypopyon. But you see that the vitreous seeding is unusual. It is very white with sort of snowballs, in the bit of infiltration of the retina. This is another example of this kind of hypopyon, which is cellular hypopyon that's moving with the eye movement. Well, it's very important to make a diagnosis, because it's completely forbidden to do a diagnostic vitrectomy or any intraocular surgery. This is the imaging. You can see that the retina is thick without a clear mass. What we are going to see more and more in Europe is the family retinoblastoma. Here you can see a family, the father, the mother that was treated at Curie for retinoblastoma, and she had two, a boy and a girl, and the two children were affected by retinoblastoma. It's very important in case of familial retinoblastoma to do an ophthalmology screening at birth. If there is a lesion, you can give an immediate treatment. If the fundus look normal, it's also very important to have an OCT to see if there is a small non-visible tumor. And if you don't have the pediatric OCT, you need to control the fundus 1 month after and every month. Here you can see a familial retinoblastoma with two, it is a fundus at birth. You have two tumors in the right eye and one tumor in the left eye, and you can treat immediately this lesion with thermotherapy. Here you can see this case. You can see nothing on the picture, and when you do the fundus, you see that there is something strange here. It's also a reflex, and when you do the OCT, you can see that there is two little tumor on the retinal layer, and you can do the thermotherapy, transpupillary thermotherapy immediately. This is a child after the treatment. So there is a lot of classification, international classification, and the new TNM. All these classifications are imperfect, but you can combine the classification. And it's important to what kind of treatment we are going to give, because the treatment is, we said in France, à la carte, it's customized. It's customized function of the age of the children, if it is bilateral or unilateral, if the classification, etc. And there is also a big deal to define the objective of the treatment is first to save the life. Then if you can save the eyeball, and if possible, save the vision. But this objective, you don't forget that the treatment had secondary side effects, and especially the irradiation. You have a higher risk of sarcoma in the radiation field. The aplasia due to chemotherapy, and disorganization of the family life, scholarity of the child, etc. We have a lot of treatment available, and more with the progress of the medicine. You have the non-conservative management, which is enucleation with or without adjuvant chemotherapy, and conservative management with IV chemotherapy, thermotherapy, transpupillary thermotherapy, thermotherapy plus carboplatin, cryo application, intraarterial of chemotherapy, intravitreal of chemotherapy, brachytherapy, but we tried to no more use the external beam radiotherapy because of the risk of sarcoma in the field. In case of unilateral retinoblastoma, if it is a very advanced case, it's probably better to do an enucleation. If it is a patient that have potential, the vision is not treated, you think you can save the globe, you can try a conservative management. So what is very important is do an MRI before the surgery to see if there is any infiltration of the optic nerve. You cannot see clinically, of course. And also to rule out the pinealoblastoma like here. And here you can see that there is an advanced case with the eye is full of tumor, and there is an infiltration of the optic nerve that end near the chiasm. And these patients need to be enucleated with neurosurgeon to cut the optic nerve as far as possible from the infiltration. In advanced retinoblastoma, sometimes you need to give neoadjuvant chemotherapy before enucleation. And if you give neoadjuvant chemotherapy before enucleation, you need to continue the chemotherapy after the enucleation, because the chemotherapy can influence the histologic risk factor, of course, because the chemotherapy will decrease the size of the tumor. If you do the enucleation without chemo, then you look at the globe on histopathology. If there is no risk factor of metastasis, you have nothing to do more. If there is some histologic risk factor, then you need to do an adjuvant chemotherapy after the enucleation. This is some examples of advanced retinoblastoma. The surgical technique is very important because the goal is to remove the eyeball without perforating the sclera and obtain at least 10 millimeters of optic nerve. And to obtain this long optic nerve, the best instrument is this snare. And with this snare, you can obtain a long optic nerve. And after, of course, you can put some hydroxyapatite or bioceramic inside the orbit. And you have a nice cosmetic results. When you look at the conservative management, you have the chemotherapy. You can give it intravenously, intraarterially, or with intravitreal injection. The radiotherapy, but as I said, we try to not to avoid the external beam radiotherapy. But sometimes we need to put a plaque, and the plaque is a good treatment for some relapses. And we have also local treatment like transpupillary thermotherapy, cryotherapy, etc. So in case of bilateral retinoblastoma, what we do in France is to start with IV chemo. And IV chemo must be used with local treatment. If the treatment is fine, you need to follow the patient. Sometimes you have relapse, and you can use second-line treatments such as intraarterial chemotherapy, intravitreal chemotherapy, etc. Sometimes you need to remove one of the two eyes when the second eye is clearly there is a persistent retinal detachment, intraocular hemorrhage complete, and you cannot see the fundus, etc. So the local treatment is transpupillary thermotherapy. You can use it alone if the tumor is small, like this. So no more than 2 the optic nerve diameter. You can also treat a small tumor on the periphery with cryo. This is the tumor and the scar after the cryo. You can, if the tumor is too big to be treated only with TTT, you can use a combination of chemotherapy and TTT. And generally, you can use carboplatin plus TTT, or sometimes, if the tumor is very big, the combination of drug plus TTT. This is another example of intra-arterial chemotherapy plus thermotherapy, transpupillary thermotherapy. And also another example of intra-arterial chemotherapy associated with transpupillary thermotherapy. If you have an invasion of the vitreous, the treatment, the most efficient treatment is intravitreal injection of or melphalan or topotecan. Here you can see there is a tumor and you have an invasion of the vitreous, and this will be nicely treated with intravitreal injection of melphalan or topotecan or both. The intravitreal injection of melphalan have been well described by Francis Munier. You need to do the injection with caution, because it's very dangerous to seed tumoral cells here with the needle. So you need to do an interchamber tap to decrease the interocular pressure, then inject the drug, and then do cryo on the needle track. This is some example of a tumor that was treated with chemo. Then you have relapse in the vitreous, and this relapse was treated nicely with intravitreal injection of melphalan. Here you can see also a relapse with 2 bubbles of tumoral cells in the vitreous, and this is easily treated with intravitreal injection. The other treatment that was quite recent is intraarterial injection of melphalan. It was described firstly by Japanese. In France, we use the intraarterial injection of melphalan only in unilateral retinoblastoma, or sometimes in very asymmetrical bilateral retinoblastoma. And in unilateral retinoblastoma, we treat all the groups except the advanced cases, so the group E, because there is clearly a risk of micrometastasis if you treat with local regional an eye with local regional treatment. You cannot treat the micrometastasis. So in very advanced cases, I don't think it's a very good idea. You can also use the intraarterial melphalan as a second line in case of relapse. Of course, there is a huge advantage that it's less toxic than intravenous chemo, but the inconvenience is that there is a clear vascular toxicity on the vessels of the choroid and the vessels of the retina. There is some brain microischemic lesion, but it's very rare. But the main issue is that you don't treat the metastatic risk. Some example of intraarterial with a huge regression of the tumor. Another case. And then after the treatment, you need to follow carefully the child, because the risk is not to see the relapse. Here you have the first lesion that was treated with intraarterial injection of melphalan plus thermotherapy TTT. And here you can see that there is the scar, and you can see here that there is some relapses in the retina. that need to be treated with a TTT. Another example of treatment with intraarterial plus intravitreal injection of melphalan. There is a nice scar, but here you have a relapse on the border that need to be treated as quick as possible. So the follow-up need to be close and prolonged every month during the first year under general anesthesia, then progressively tapered every 3 months. And you can do the fundus without anesthesia generally after the age of 4. And of course, you need to check all the retina to the other serrata because the relapse generally occur in the periphery of the retina. Here we have an example of relapses, diffuse relapses after the treatment of the first tumor. And here you have some relapses that need to be treated quickly. So in conclusion, each child needs to have a customized treatment depending on the laterality, the staging, the age, etc. Chemotherapy alone is often non-sufficient, and you need to give also additional treatment like cryo or TTT. There is a lot of progress with the local regional treatment, but to avoid the external beam radiotherapy. But you need to know that this local regional treatment don't prevent the risk of micrometastasis. And of course, the child needs a close follow-up after the treatment. Thank you.
Thank you very much, Natalie, for the wonderful talk. I've got a question. In cases of conditions that show similarities with retinoblastoma, like CODS, would you suggest MRI? And do you think it's necessary? And what do you think?
Sometimes, yes. If the cost is non-advanced, it's easy to do the diagnosis because you have the telangiectasia, and the exudation is yellow, it's not white. But sometimes you have a complete retinal detachment, and it looks like retinoblastoma.
Exactly.
So in that case, you need an ecography and an MRI, and there is I think that a paper is going to be published by the group of the neuroradiologist with a sign to distinguish the retinoblastoma from the advanced coats.
Okay.
And at the end, sometime in cases you cannot really make the difference between a retinoblastoma and a coats.
Exactly.
Sometimes it's once a year or every 2 years. You need to do an enucleation and to explain to the parents that it's better to enucleate an eye with an advanced coast than to let it evolve a retinoblastoma.
Okay. Thank you very much. So let's go now to your next talk. You're going to speak about the management of uveal melanoma. If you have any questions, please type your questions in the appropriated box, and I'm going to ask the questions at the end of the talk. So Natalie, to you for the next talk.
Okay, so let's the management of another ocular tumor in the adult. This time is the melanoma, uveal melanoma. So the treatment for uveal melanoma, you can use the combination of radiotherapy or surgery or both. It's the same that all these techniques need to be tailored to the tumor size, location, extension, and patient situation and wishes. The treatment is also choose function of the country, healthcare resources, etc. What we know is that the risk of metastasis is not affected by what treatment you are going to choose, enucleation or irradiation. In France, we are organized in a national network called Melaconat, and this network, the treatment follow some national guidelines we have wrote. It is exactly the same our first goal, because we are oncologists first, is to save the patient life. And this is related to an early diagnosis, and we need to do a lot of education of professionals. And it's one of the mission of this French network is to do many courses in France for the early diagnosis of melanoma. And the patient need to be sent to a referral center for appropriate treatment. And if you can, we are going to try to save the patient eye by conservative management. And if possible, we are trying to save the patient visual acuity. This old treatment, that is the enucleation, remains necessary for advanced cases. What we mean by advanced cases is very large tumor associated with total retinal detachment or neovascular glaucoma or melanoma that infiltrate all the eyeball. There is generally tumor with a basal diameter, large basal diameter and a thickness over 10 millimeter. In this case, radiotherapy, either by plaque or proton beam, will be associated with a large amount of complication. The eye will become blind and painful. You need to have you risk also to have relapses. So in this case, you need to discuss with the patient if he really want a conservative management and to have a lot of complication, or if he agreed to have an enucleation that will be cosmetically better to do a first enucleation than to do a secondary enucleation after irradiation. Here you can see that this is the risk of secondary enucleation function of the following irradiation, depending on the thickness of the tumor. The more the tumor is thick, the more the risk of secondary enucleation is high. So this kind of big tumor, you need to discuss frankly with the patients, because if you want to keep his eye, he will have a lot of problems. The enucleation is exactly the same that I said previously. We use a snake. And of course, we put ceramic in the eye. For the conservative treatment, the first goal of this conservative management is to obtain a local control. So to stop the evolution of the melanoma and perhaps prevent metastasis. I said perhaps because it's impossible to prove. What is sure is that when you treat a small melanoma, you have few metastases. And the bigger the tumor is, of course, the risk of metastasis increase. Secondly, to preserve the eyeball and sight if possible. The treatment by irradiation induces many side effects. And as I said, the complications are more frequent and more severe function of the tumor volume. So how to improve this eye preservation and sight? But at the same time, we need to stay efficient in terms of tumor control. And the melanoma is a tumor that is radio-resistant. We need to give a high dose of irradiation to control the tumor. So the first step is to customize the treatment. We need to decide if you are going to do proton beam or a brachytherapy. And for brachytherapy, you have a different kind of plaques, iodine plaques, ruthenium plaques, and which is less used, palladium plaque, for example. The brachytherapy, it's generally the radioisotope is here, for example, you have a seed of iode, and you can see that the seed irradiate around him. If you put the seed in gold, the irradiation will go in the direction of the eye, and the gold will protect the lacrimal gland, the eyelid, etc. So this iodine plaque is surgically sutured on the sclera and will irradiate the tumor. To destroy the melanoma, you need to put 90 gray to the top. So you can see that the dose is not homogeneous to the tumor, because you have more and more irradiation when you are near the sclera. This is one inconvenience of the brachytherapy. And the second inconvenience of brachytherapy, and especially with iodine, is that there is a diffusion laterally. And this lateral diffusion, will increase the side effects. On the contrary, the proton beam will give an homogeneous dose to the tumor, because the tumor will be irradiated in the Bragg peak, in the modified Bragg peak. And there is no diffusion on the laterally. And this will decrease the side effects. The choice is function of the position and the size of the tumor. The tumors that are located at the posterior pole, the proton beam is the more efficient technique to my point of view. We know that we have done a study, and we have shown that for T1 tumor located at the posterior pole, we have 100% of local control with proton beam, and a preservation of the visual acuity when the tumor is located at more than 3 millimeters from the macula or the optic nerve. There is also a very, very big study done by the Shields with brachytherapy. The visual results is not so bad, but it's not as good as our results. And what we can see, there is more relapse with plaque. And I'll show you why, because for all the tumors that are located at the posterior pole, it's very difficult to put a plaque. And especially for tumors that are located around the optic nerve, or that invade the optic nerve, because even with notch plaque, it's very difficult to irradiate around the optic nerve. This kind of tumor also is very difficult to treat with the plaque, but it's easy to treat this tumor with proton beam. This is an example of a melanoma that was treated with a plaque. And here you can see that there is a relapse that is due to the lack of treatment of probably this border of the tumor. So the advantage of the proton beam is a target external beam radiotherapy. But because it's an external beam radiotherapy, it's not indicated if the tumor is located in the temporal superior quadrant, because in that case, you will irradiate the lacrimal gland, and the patient can complain of severe dry eye. It's also impossible to do a proton beam if the patient is not compliant, or if he has a dementia or some psychiatric issues. And the other point is that the more the tumor is sick, the more you can face a toxic syndrome. This toxic syndrome is due to necrosis of the tumor that increase the retinal detachment or give a retinal detachment that can be total, and the patient can develop a neovascular glaucoma. Here you can see in this Kaplan-Meier curve, then the more the tumor is thick, the more you have a risk of neovascular glaucoma. To prevent this toxic syndrome, you can combine the proton beam with surgery, that is an endoresection of the scar. It's a 3 posts per planar vitrectomy. Then you remove the tumor and you do laser and you put silicone oil inside the eye. But it's for me, it's important to do the endoresection after the destruction of the tumoral cells by proton beam. You need to inactivate the tumoral cells. And this surgery decreases the risk of neovascular glaucoma and the risk of secondary enucleation. This is an example of very big melanoma. The top is mask the posterior pole. After proton beam plus endoresection of the tumor, here you can see there is a coloboma, and the posterior pole is perfect, and the patient has good vision. This is another case of a big tumor that was treated with proton beam, then endoresection of the scar. You see here, this is the sclera, the coloboma due to the removal of the tumor and everything, and the retina, etc. But in this case, the visual acuity is not so good because the macula was irradiated with the tumor. You can also combine other adjuvant treatment, such as intravitreal injection of anti-VEGF plus photocoagulation with laser. Here you can see that this patient need something because he was treated for this small tumor, and you can see that there is many signs of irradiation retinopathy. And in this patient, the tumor is very well controlled. The patient get his laser with intravitreal injection. He didn't develop any glaucoma, but the vision is not so good because there is, of course, irradiation of the macula. This is another example. See that this is a small melanoma, and after radiation, we know now that there is an occlusion of the capillary of the retina in all the layer. And in this case, you can see that there is also an ischemia of the choroid, plus a very huge occlusion of all the capillaries of the retina. Sorry, I didn't translate. So what we choose is if the melanoma is located at the posterior pole, we are using proton beam. If the patient is non-compliant, or if it's not possible to put a plaque, it's not possible to put the patients at the proton beam facility, we can use a plaque. If the melanoma is anterior to the equator, we can use proton beam except if the location is superior temporally. And in that case, we put a plaque. If the tumor is less than 6 millimeter, you can use a ruthenium plaque or iodine plaque. But if the tumor is over 6 millimeter in thickness, the ruthenium can be not enough, not sufficient. So it's better to use the iodine. This is a difference between an iodine plaque and a ruthenium plaque. This is gold, this is silver, but this is not the main point. You can see that this is here you have the dosimetry of the ruthenium, and here you have the dosimetry of the iodine plaque. You see that this with iodine plaque, you have an irradiation that is more important in depth. That's why you can irradiate a tumor until 10 millimeter in thickness. But the inconvenience is that there is laterally a lot of irradiation, and that increases the toxicity. For the ruthenium plaque, the depth of irradiation is less important. That's why you cannot irradiate tumors of more than 6-7 millimeters. but the toxicity is less important because the lateral irradiation is less important. This is an example of an iodine plaque that was sutured on the eye surface. This is an example of ciliary body, ciliochoroidal huge melanoma. After the irradiation with iodine plaque, here the scar is not visible because it's far in the periphery, and the patient is well. This is an example of a ruthenium plaque and irradiation before and after the ruthenium, and these pictures came from Anne Schallenbourg. So in conclusion, whatever the treatment you use, you can get a nice tumor control. The risk of metastasis, either with enucleation, brachytherapy, or proton beam, is equivalent, and it depends on the TNM classification at onset, the genomic and mutational status of the tumoral cells. Here you can see the price. You can see that the brachytherapy is cheaper than proton beam. But if you can combine the two techniques, you can provide a very good treatment to the patient. What we need to work now is to improve the proton beam. We have some new protocol with what you call flash proton beam. It's a technique that delivers the doses with better sparing of the normal tissue. But this new proton beam technique is for the moment only on mice. Thank you.
Thank you very much, Natalie. I've got a question. So what's your thought about the gamma knife treatment and choroidal melanoma?
The gamma knife is an external beam radiotherapy, and there is not only one beam, but many beams. And all these beams are focused on the melanoma. So it's efficient. You can destroy a melanoma, but it's more toxic because you have the toxicity at each point of the beam, of each beam. So in fact, you increase the toxicity by the fact that you have many beams that enter in the eye instead of one beam with the proton beam.
Okay.
So it's more toxic.
And what's your thought about PDT in cases of small metastatic melanoma or non-pigmented melanoma? Do you use PDT at all or no?
No, I'm not convinced.
Okay, thank you very, very much for both of your talks. Thanks for your kindness to cover also the talk of Vicky.
Yeah, and I hope she's better.
I hope she's better as well. Thank you very much. Bye.
Thank you. Bye-bye.
Bye-bye. So we're going now to our next speaker, and we are really greatly honored to have today with us Dr. Damato. For who doesn't know, Dr. Damato founded the Ocular Oncology service at the Royal Liverpool University Hospital and directed this service until 2013. And then he has then invited to renovate the Ocular Oncology service at the University of California, San Francisco, which he directed this service until 2018. And recently, he has founded also the Ocular Oncology service at Oxford Eye Hospital. He has been recipient of several international prizes, has published more than 200 peer-reviewed articles, 68 reviews, 75 book chapters, and 6 books. He has served as president of our European Ocular Oncology Group and also of our International Society, president of our International Society of Ocular Oncology. Dr. Damato will talk to us today about how we could diagnose fundus tumors in adults. We have occasions where we're wondering if this is choroidal nevus or choroidal melanoma, or some cases we have overlapping features between choroidal nevus and small melanoma. So, Dr. Damato, enlighten us. To you.
I'm delighted to be here. Thank you for your
We
invitation.
wish you could be here, actually.
So let's try the screen share.
Okay.
There we go. Is that okay? Can you see the screen?
No, yes.
Yeah. So I'm going to speak about diagnosis of adult ocular tumors. And there are many intraocular tumors, which I can't speak about in 20 minutes. And so I'm going to address 3 questions to differentiate nevus from melanoma, melanoma from metastasis, and metastasis from lymphoma, because those are the really life-threatening conditions. So with regards to distinguishing nevus from melanoma, I have put together the acronym MOLES, which is the lay term for nevi in English. A mole stands for mushroom shape, orange pigment, large size, enlargement of the tumor, and subretinal fluid. Each of these is given a score of 0 to 2. So mushroom shape has got a score of 0 if the tumor is flat or dome-shaped. It's got a score of 1 if there's just a little bit of invasion into the retina, and a score of 2 if there's a definite mushroom shape with an overhang. Orange pigment is given a score of 0 if it's absent, 1 if there's only trace amounts, a slight dusting, and 2 if there's confluent clumps of orange pigment. OCT is useful for distinguishing orange pigment from drusen, because because orange pigment, lipofuscin, is anterior to the RPE, whereas drusen are present under the RPE. Large size is categorized as small if the diameter is less than 3 dis diameters and the thickness is less than 1. Borderline if the diameter is 3 to 4 dis diameters, or if the thickness is 1 to 2 millimeters. And 2 as large if the tumor diameter is more than 4 dis diameters, or if the thickness is more than 2. Color photography, I think, is the best way to look at diameter of these tumors, because with ultrasonography, it's very difficult to tell where the edges are, especially if the tumor is flat. And OCT, for very small tumors, if you can see the sclera, is probably more accurate than ultrasonography. And next is enlargement. 0 if there's no enlargement, 1 if there's uncertain enlargement, and 2 if there's definite enlargement detected by sequential photography. And the best way to notice enlargement is by looking at the distances between the margins of the lesion and the adjacent landmarks. And finally, subretinal fluid. 0 if there's no subretinal fluid, even if there is intraretinal edema, that's 0. 1 if there's trace amounts of subretinal fluid, visible only on OCT, and 2 if there's enough subretinal fluid to be visible ophthalmoscopically. So I've prepared a scoring system. Each of these is scored between 0 and 2, and then you add them all up and to get the total score. And if the total score is 0, that's a common nevus present in 6% of the population. And those patients are reviewed by an optometrist or in the community every 2 years. 1, a low-risk nevus. You see the patient every 12 months. 2, a high-risk nevus, review every 6 months. And 3 or more, a probable melanoma, refer urgently to an ocular oncologist. The reason why probable melanoma is firstly because this system is not designed to differentiate between melanomas and metastases and other conditions. And secondly, non-experts may lack the confidence to categorically diagnose melanoma. So I've designed a referral form, which is being used at Oxford Eye Infirmary, where I'm working, and at Moorfields Eye Infirmary. And this form, the PDF, automatically estimates the total score, the diagnosis, and the recommended treatment. And we insist on the referring practitioner sending us a picture of the tumor so that we can triage the patient and perhaps give a report without the patient coming to hospital. And if you want to find out about this, you can Google Oxford Ocular Moles Service. So here's an example of a common nevus with no risk factors. Proximity of the tumor to the optic disc is not a risk factor for malignancy. Score of 1, because it's big. 2, very big, but no retinal detachment or orange pigment, just lots of drusen. And a score of 3 with confluent orange pigment, subretinal fluid. This is a probable melanoma. And here's another probable melanoma, because despite the small size, the tumor has invaded through pigment epithelium and retina to develop a mushroom shape, an early mushroom shape. So you may have heard about the mnemonic to find small ocular melanoma: thickness, fluid, symptoms, orange pigment, and M for melanoma hollow on ultrasound. But the problem is that a lot of people don't have access to very sensitive ultrasonography equipment, or they don't have the skills to look at acoustic hollowness on ultrasonography, especially if the tumor is very, very thin. Previously, M represented margin near disc, but since it was found to be insignificant, that's been cancelled. So the mole system is very useful for distinguishing nevi from melanomas. It's been validated externally and it's doing very well. But there's still some patients who are uncertain, and if you give radiotherapy, just in case, it's going to cause a lot of ocular morbidity. And for these patients, you might want to perform a biopsy. And here's a tumor which has been biopsied successfully, even though the thickness is only about 0.6 millimeters. So an expert can biopsy very thin tumors. So in summary, one way to distinguish nevi from melanomas is to follow the moles system. It only needs color photography and OCT, and if possible, autofluorescence, and it's working well. Now we speak about the difference between melanomas and metastases. Melanomas can, if they're amelanotic, can be very similar. They can have leopard spots like metastases, which consist of lipofuscin. Here you can see the autofluorescence. And they can have a slightly wavy surface. The main differences between melanomas and metastases are that they're darker on ultrasound than metastases. And on OCT, metastases have got this lumpy surface, which melanomas don't have. And thirdly, with melanomas, you can usually see blood vessels within the tumor, which you can't see in metastases. Clinical features of metastases, they can be multiple, unlike melanomas, but quite often they are solitary. The color depends on the camera to a large extent, although there is a bit of variation between patients too. And very rarely you can get intraretinal metastases or vitreous metastases or optic disc metastases. Here's a metastasis. You can see the difference between Optos and other cameras. There's a medium reflectivity, a lumpy surface, and on autofluorescence, there's this sort of faint stippling. Here are metastases in a patient from cutaneous melanoma, and also metastasis in we can't see it there because it's there we are, in the caruncle, in the conjunctiva, And with systemic treatments, the metastases have regressed, the lumpy surface has disappeared, the choroidal vessels have come back again, and the caruncular tumor has gone, but there's been whitening of the skin and of the lashes. So, as I said, ultrasound can be useful. The reflectivity is lower in melanomas than in metastases. And melanomas quite often have this mushroom shape, which is very rare with metastasis. And when you do have a mushroom shape with metastasis, you don't have a dark area in the deep area. Biopsy is very useful, transsclerally or transretinally, to distinguish melanoma from metastasis, and perhaps to identify the source of the metastasis, whether it's starting in lung or somewhere else, if it's an occult primary. Many do a biopsy only after lots of systemic investigations. If possible, I prefer biopsy first, and then the result guides the investigations afterwards. Finally, I'm going to speak about metastasis versus lymphoma. They can look quite similar occasionally. Lymphomas are large, high-grade, diffuse large B-cell lymphomas, and with a multilobulated nucleus, and they spread from an unknown source, perhaps bone marrow, to the CNS, the eye, and sometimes to the testis. This is my understanding of how the ocular disease for vitreoretinal lymphoma develops. First, it spreads through the retinal arterioles into the retina, and sometimes you can see sheathing. And I suspect this because when you see that, you get occlusion of the retinal arterioles, and so you see the subpigment epithelial, the pigment epithelial abnormalities everywhere except where you get that protective vascular occlusion. From the retina, the tumor cells pass through the pigment epithelium until they reach the Bruch's membrane, and then they get stuck at Bruch's membrane, and then they accumulate between the pigment epithelium and Bruch's membrane. Quite a few people have told me, how can lymphoma cells pass through the pigment epithelium? But you can get the same phenomenon with retinoblastoma. Apart from traveling through the pigment epithelium into the subpigment epithelial space, these cells infiltrate the vitreous to form pearls and clouds, and from the vitreous they can go back into the retina again, or else they can go into the anterior chamber. So the clinical features are these subpigment epithelial deposits, which are hyper-autofluorescent. But then when they regress, they cause atrophy of the pigment epithelium, which is hypo-autofluorescent. And then the vitreous infiltrates also cause clouding in color photography and autofluorescence imaging. And the vitreoretinal lymphomas tend to cause these kinds of patterns. OCT is very useful. Here you can see intraretinal infiltrates with lymphoma and subretinal and pre-pigment epithelial infiltrates, subpigment epithelial infiltrates between the pigment epithelium and Bruch's membrane. And then if under the fovea, you can get fibrosis. You can also get macular edema and epiretinal membranes in these patients. So one way to diagnose these is to do a subpigment epithelial biopsy, but these big masses mostly consist of necrotic tissue. And so it's important to take the sample as deep as possible, as close to the chora capillaris as possible. And it's really important to get the specimen to the laboratory within an hour, unless you use a special fixative. And then for vitreous biopsies and even subretinal biopsies, you look for infectious agents, immunohistochemistry to identify the cells, the clonality studies, cytokines, gene translocations, look for infectious agents, and mutations such as MYD88. And in San Francisco, they've developed this metagenomic deep sequencing, which is wonderful because it distinguishes DNA from humans, as in lymphoma, from DNA from infectious organisms. And it is successful even with tiny amounts. So I think we'll be hearing more about this in the future. So in conclusion, to distinguish nevus from melanoma, you may want to try the MOLES acronym and scoring system. And if that doesn't, using OCT, autofluorescence, sequential color photography, and perhaps biopsy in some cases. To distinguish melanoma from metastasis, OCT is very useful, ultrasound and biopsy in selected cases. And to distinguish metastasis from lymphoma, OCT, very useful, fundus autofluorescence, really useful, and biopsy is extremely useful in that condition. So I'd like to thank my past and present colleagues, and I'd like to thank you for your attention. Thank you.
Thank you very, very much, Dr. Damato. As always, your talks are always very interesting. I've got a question from you, from Dr. Andreas Papandroulis. He was asking if there are any risk from biopsy to differentiate melanoma from metastasis. Do we need a special care for biopsy?
What risk are you referring to?
To differentiate melanoma from metastasis.
Right, the important thing is to get a good sample, to take several samples so that you get enough for the pathologist, so that the pathologist can do immunohistochemistry. That's really, really important. Mm-hmm. And if they find that it's a melanoma, then it's very, very useful for them to do genetic analysis to determine whether or not the tumor has got metastatic potential.
And is there any special care for biopsy needed or no?
For biopsy?
No, yeah.
Well, it's important to consult the pathologist before doing the biopsy to make sure that they're ready for the specimen, that you've agreed on the transport medium, and all those kinds of things, especially if you biopsy suspected lymphoma. Mm-hmm. There are a lot of people who are afraid that the biopsy might disseminate tumor liver to cause metastasis. Well, metastasis is a very, very complex phenomenon, and it's unlikely that the physical manipulation will actually make the tumor cells go into the blood, and from the blood to the liver and so on. But the biopsy, if it's not done properly, can cause local seeding. I've seen seeding into the subconjunctival tissues, and I've seen seeding even into the retina. So you've got to avoid local seeding.
Okay, and they were asking again about the risks of biopsy.
Well, I've spoken about the local seeding. I've said that biopsy does not cause metastasis of melanoma and metastasis and lymphoma. Mm-hmm. One risk is that patients might be afraid of that. And if they do get metastatic disease, they might say it's because of the biopsy. Yeah. And so it's important to speak to the patient before doing the biopsy, mm-hmm. to explain to them about the safety of the biopsy.
Okay. Thank you very, very much for joining us this afternoon.
Thank you.
Thank you very much. So we're going to our next speaker. It's my very great pleasure to welcome Dr. Shahar Frenkel, who will talk to us about the tumors of anterior segment. Dr. Frenkel is professor of ophthalmology at the Hebrew University of Jerusalem and chief of the Ocular Oncology department of Hadassah Medical Center. among all the other things, has a research laboratory that employs molecular biology techniques to study the genetic procedures that cause ocular malignancies and metastases from the tumors of the ocular surface in order to improve the diagnosis of these tumors and to better treat them. Sahar, I'm so happy to see you because I know that you had an emergency this morning and you tried your best to be here, so I'm very happy to see you.
Thank you very much. It was indeed a really tiresome day, but I managed to make it at the last moment.
And we're happy for this.
Only because I care about you so much and I didn't want to disappoint you.
Okay.
I'm gonna
share your screen.
Slides.
Mm-hmm.
Okay, so we're gonna talk now about conjunctival tumors. And as Professor Damato said before me, there's a whole variety which I cannot cover everything, but I put here a set of slides of the highlights of what you could be interested in. And so the important thing is, first of all, to realize where are we in the eye. And if we look in the image here, we see the eyelids, and next to them, we see the conjunctival lining, which also covers the eye. And it is important to remember that conjunctiva is not only what we see when the patient opens their eyes. But basically, when we talk about ocular surface epithelial tumors, we're talking about acanthosis, thickening of the epithelium with intraepithelial dysplasia, with changes that you can see here on the right, ranging from squamous papilloma, or you see the histology, through conjunctival intraepithelial neoplasia, which can be mildly atypical or severely atypical. The premalignant epithelial lesions, the CIN, can transform into squamous cell carcinoma, which is malignant. And in a few slides, you will see why it's important to distinguish between them. But in the histology slide here, you see the transition from normal epithelium to thickened acanthotic dysplastic epithelium. It is very clear to see histologically, as you can see in these pictures clinically, although clinically you don't always see the full extension of the lesion. It can start anywhere in the epithelium, and if it covers the cornea, I'm not sure you can see this here, but there's some haze on the superior half of the cornea here, because all the epithelium here is irregular. And if you put fluorescein, you see all this irregular epithelium. The severity of the thickness of epithelium involved determines the severity of the CIN, be it mild, moderate, or severe. When it's full thickness, just like here, then we call it carcinoma in situ, squamous cell carcinoma in situ. And squamous carcinoma in situ entails when the dysplastic cells invade through the epithelial basement membrane deep into the underlying stroma, and you can see here a wide variety of what these lesions may look like. However, when something looks very similar to it, but in histology you see foamy cells, and you see pagetoid spread, you see islets of cells spreading throughout with sometimes skip lesions throughout the epithelium, then we're talking about sebaceous carcinoma, which is a completely different entity. And if you have a good suspicion, you have to ask your pathologist specifically about this, because dermatopathologists who are not ophthalmic pathologists may sometimes miss these diagnoses. And I've just seen a case like this week. And why do we have to send every lesion that we remove from the conjunctiva to pathology? Because we've seen cases of quote unquote recurrent pterygium, which were actually OSSN, ocular surface squamous neoplasia, and they were on the severe spectrum of it, and there were squamous cell carcinoma, which eventually invaded into the eye, surrounded the eye, and filled the orbit, and ended up in exenteration. So even if you're sure this is a pterygium please send it to pathology to be sure that this was only a pterygium. If you want to be sure, you can have a small assistance from a simple dye called toluidine blue. Two papers from 2013 and 2015 have shown that a high range of premalignant and malignant lesions stain with toluidine blue. However, this is not a very specific staining. You put a dot on the eye, you can see the patient here. There's a spillage of this dye outside. Even if you put only one drop, you have to warn the patient in advance that they will come out looking like you punched them in the eye. So tell them in advance and tell them it comes off with water and some soap. But this is very helpful because you can see it stains the epithelium. In one study, 90% of premalignant lesions and 100% of malignant lesions stained with 0.1% toluidine blue. In another study, using only 0.05%, they had 92% sensitivity and only 31% specificity, meaning if it's positive, it's worthwhile to take the lesion out. It doesn't mean that it will necessarily be malignant, but if it's positive and if it's negative, you have 88% of negative predictive value. If it's negative, probably it's not malignant. Now I want to give a little time to talk about how you send those specimens to pathology, because this is really important. If you don't do it correctly, the pathologist cannot help you. And the whole purpose of a biopsy, and Professor Damato also talked about biopsies and how you should procure them, but he didn't speak about how you send them away to the pathologist. And especially in ocular surface lesions, this is extremely important because you see here before you an example of what you shouldn't receive. This is crunched up tissue, squashed by the forceps here. You can't tell where the epithelium is. You can't give a diagnosis. You don't know what the margins are like. And this is just like junk material. What you want to see are all the layers, and how will you get to do that? So, first of all, if you have a part over the cornea, you have to remove it. And here you see pictures of a colleague who uses a crescent blade. This is something I want to discourage you from ever doing, to something that is even remotely suspicious of being malignant. Because if you use a crescent blade, you do not follow the normal planes of the tissue. You create new planes. While doing that, if this was a malignant lesion and it recurs, it will invade into the stroma of the cornea and you will never be able to remove it. So what I recommend using is a hockey blade. You see it down here and you see a magnification of the tip. Although it looks sharp, it is not sharp. And you use it to scrape the tissue away. Some others suggest using alcohol over the lesion to loosen the hemidesmosomes connecting the epithelium to the basement membrane, and thus loosening the epithelium from the underlying tissue, and then you can remove intraepithelial lesions. By the way, if it doesn't help either with alcohol or with a hockey blade, it means that you already have invasion. So you have a very good clinical suspicion in the operating room without seeing the pathology that this would be a malignant lesion. But after you've removed the epithelial part, you have to remove the corneal part, you have to remove the conjunctival part. Once you do that, you have to spread the tissue very well, so you will not have crunched up tissue. We use the paper that wraps the gloves, the surgical glove which you receive. You cut a square of it and you place, usually you have a piece of cardboard to show you as an indicator that everything is sterile in your kit. And you can use this cardboard to spread the tissue over it, or if you use a wax sponge like in the picture here on the left, you can spread the tissue on the wax sponge cut away the sponge from the stick and put it in the paper. And then you fold the paper over the tissue, fold it nicely, and you put this in the formalin container. If you keep this, the tissue will be fixed flat, and then you will be able to see the entirety of the lesion. Moreover, it is important to tell your pathologist where you took this from. And so the pathologist will know where are the margins, and he will be able, or she will be able to tell you if you have invasion of which margin. If you do it right, this is what it comes out. Like you see a very nice flat lesion. So once we know how to take these lesions out, we're going to move to the ocular surface pigmented lesions. And you have a whole variety of them, ranging from ocular melanosis, which isn't really in the conjunctiva, through complexion-related melanosis, which is in people with darker skin tone. Used to be called racial melanosis, but then someone said if all the pathologists were from African ancestry, then people like me would have conjunctival amelanosis, racial amelanosis. So they changed the terminology, and now it's complexion-related melanosis. When you have darker complexion, you may have this pigmentation on your conjunctiva, usually only in the horizontal plane, at 3 and 9 o'clock. Nevi, many times have cysts in them. And if you see cysts inside such a lesion in the conjunctiva, this is a really good indication that this lesion is benign. Then we move to pre-malignant lesions, such as primary acquired melanosis, and they come in two varieties, without and with atypia. Clinically, you cannot discern between them. Primary acquired melanosis without atypia usually looks like someone took a container of cinnamon dust and sparkled it, peppered it over the conjunctiva. You see fine grainy patches of pigment. When there is atypia, in many cases, it is more widespread, and sometimes you have darker areas as well. And this range of non-malignant lesions ends with conjunctival melanoma, which you see in the bottom picture. Now, I put this caruncular lesion here under nevus because this specifically is a nevus. But this is a very dangerous location. If this is not a nevus and a melanoma, this is much more likely, just like the tarsal conjunctiva, a pigmented lesion in this location is more likely to be a melanoma than a nevus and must always be removed, especially if this is a new lesion. Now, when we look at PAM, not all the melanocytes produce melanin. So here I show you with a blue margin the entire extent of this PAM. Although clinically, initially, you only see pigmentation in a very limited area. So you have to remove this lesion. Histologically, you see the difference between non-atypia, which look like a variety of nuts arranged on a windowsill or on a tabletop. All the nuclei look a bit different, but they are all lined one next to the other. Once they start clumping one on top of the other, then you get atypia. Here in this histological picture, you see severe atypia. But still, not all of these melanocytes may produce melanin, so you don't always see the entire extent of it. So, if you want to do a complete excision, it is not always possible because you cannot detect the margins. So there are two techniques of how to approach this problem. But before that, I will tell you a few more things about melanoma, which also has to be resected in the same way because of the same issue of non-pigmented melanocytes. The annual incidence of conjunctival melanoma is very low. It's only 0.2 to 0.3 per million cases a year. And most of them, 2/3 of them arise from primary acquired melanosis with atypia. Only 20% arise from nevi, and the rest are de novo. Conjunctival melanoma is about 1 to 500 less common than skin melanoma, but still it is an important disease to remember. not always do you see the melanoma. For example, this patient looks completely normal when he comes to you. But if you invert the eyelid, you see this very serious mass of melanoma on the tarsal conjunctiva. So any suspected pigmentation that you see on the bulbar conjunctiva, you must invert the eyelids. And I would suggest that you invert every eyelid of a new patient that you see, even if you don't see any pigmentation. Speaking about conjunctival melanoma versus skin melanoma, then there is a common mutation, a BRAF mutation. It is present in about 50% of nevi, doesn't appear at all in primary acquired melanosis, be it with or without atypia, and appears in 40% of conjunctival melanomas. So it is not really useful in diagnosing melanoma because this could also be a nevus. But we should remember that this is closer to skin melanoma than uveal melanoma. Invasion deep into the tissue varies between 0.8 to 4 millimeters, resulting in a decreased trend in prognosis without a clear cutoff value. In skin melanoma, there is a cutoff value. In conjunctival, there isn't. Local recurrence has been reported in about 50% of patients after about 2.5 years. So what do you do with it if you don't know how to remove everything? So there's one technique called the no-touch technique, where, as you can see here in A, you take very wide margins, about 4 millimeters around the lesion, and then you do cryo of all the margins and the tumor bed. And then if you have a large enough gap that you cannot close, you put an amniotic membrane to help close it. The surgical results are okay. Another management technique is to use strontium plaques. These are beta radiation plaques. You put it for a few minutes on the lesion and you finish the radiation. However, if you do cryotherapy, there's a long list of risks. You risk symplephone, corneal edema and scarring, vascularization, iritis, peripheral iris atrophy, IOP changes, peripheral retinal changes, cataract, ectropion. So this is why we do not do this technique. We prefer to use either brachytherapy, but strontium plaques are only available there's one in London, maybe one in Moscow, but in most places you don't have them. And it doesn't help you differentiate between all those other lesions. By the way, a benign inflamed juvenile conjunctival lesion does not need this, but the melanoma will. So we prefer to use adjuvant local therapy, and you can do it with chemotherapy like mitomycin C, with 0.02% for epithelial lesions and 0.03% for pigmented lesions. The downside of this is that you get, with repeated treatments, you get limbal stem cell ischemia, limbal stem cell deficiency. 5-fluorouracil is mostly used in Italy. And interferon alpha-2b or alpha-2a is useful, and I'll show you in a minute, and plaque brachytherapy over the lesion. One of the great promoters of plaque brachytherapy over these lesions was Professor Damato, who spoke before me. Regarding the local chemotherapy, it is good for intraepithelial lesions, be them CIN, even up to carcinoma in situ, but not good for invasive squamous cell carcinoma. And it is good for primary acquired melanosis with atypia, but not for invasive malignant melanoma. In these cases, you must put a plaque. If it is not invasive, you can use interferon. Look at this. This patient was treated with multiple treatments of mitomycin C, kept having recurrences, and then she was treated with interferon. And look at the clearing of all the pigmentation from her bulbar and tarsal conjunctiva and the eyelid margin. Everything went away. So this is very effective immunotherapy against melanoma. When you talk about brachytherapy, we use ruthenium plaques in comparison to iodine plaques. Those are very large. I don't know how anyone can put them over the conjunctiva. They're really too big and they will interfere with closure of the eyelids. And ruthenium plaques are so thin, it doesn't bother the patient to close the eye. You make 2 holes in the conjunctiva, suture the plaque to the sclera, and you're done. But what happens if it's the tarsal conjunctiva? There's a convexity of the plaque, and it is the reverse of the convexity of the tarsus. So I've invented a surgical technique, which I call sandwich technique. You see this at the bottom left corner, you see this conjunctival melanoma of the tarsal conjunctiva. You slip the radioactive plaque facing the tarsus, but you don't want to irradiate everyone around them. So you use the demi-plaque on the other side, and you suture them together. And then you block all the radiation coming from the plaque. Only the eyelid tumor gets irradiated. So in this sandwich technique, you manage to treat even tarsal conjunctival lesions. And so I hope that with this quick tour of conjunctival epithelial and pigmented tumors and treatment options and why I personally advocate some treatment modalities over others, I hope this helps. I hope you remember the pathology tips so your pathologist appreciates how you send in tissue, and then you get better pathology reports to help you diagnose and treat your patients. Thank you very much for your attention and for staying this late. And I transfer the microphone back.
Thank you very, very much, Sahar. Your talk was very, very interesting. I've got a question for you. Do you think as a diagnostic procedure, UBM or anterior segment OCT would be more useful in the diagnosis of ocular tumors? What would you use and in which condition? Or if you have to prefer one?
So I actually forgot to put a slide of anterior segment or ultrasound and OCT into my presentation due to this emergency this morning.
So you can answer now. If
you have any suspicion that a squamous cell carcinoma or a conjunctival melanoma is invasive into the eye, you would use anterior segment ultrasound. But if you're only looking about the epithelium and the minor invasion of non-very thick lesions, then anterior segment OCT is wonderful.
Okay.
And if we have another
conjunctival lymphoma?
Well, lymphoma, I'm not sure this would be helpful in the anterior segment at all. Lymphoma looks salmon patch. You differentiate lymphoma from inflammation by a biopsy. And you have to have a very good pathologist specialized in lymphoma to differentiate these lesions. And so to differentiate lymphoma, you have to have a biopsy.
Okay. Thank you very much. Thanks for joining us this evening. And I hope that this course today addressed some of the issues relating to the fields of ocular oncology. Thank you to all the speakers for taking the time from their busy schedules to join me for this occasion, and a huge thanks for all the participants. Εύχομαι κάθε επιτυχία στη συνέχεια του συνεδρίου και κυρίως εύχομαι αυτή η παγκόσμια δοκιμασία της πανδημίας να τελειώσει σύντομα και να μπορέσουμε στο άμεσο μέλλον να μοιραστούμε τη γνώση, αλλά και συνδυασμό όμως με το πολύ ακριβό αγαθό της άμεσης επικοινωνίας. Μετά από μένα θα ακολουθήσει το session της οφθαλμοπλαστικής χειρουργικής με εξαίρετους συναδέλφους τον κύριο Νουμελώτη και τον κύριο Χαρώνη. Ευχαριστούμε πολύ.